Okay, good afternoon, everyone. We'll start now. Thank you for joining our webinar today. My name is Emily White-Johansson. I am the Deputy Chief of Party for Breakthrough Research. I'm filling in today for Dele Abagunde, who's our Chief of Party, who's on vacation, unfortunately. And so we, as you know, are conducting a series of webinar events to share evidence on psychosocial influences related to maternal, newborn, and child health and nutrition, as well as malaria and family planning. And these webinar series will be going on between July and September every few weeks. And so today, this webinar focuses on the psychosocial influences on breastfeeding practices in Sokoto, Kebbi, and Zamfara states. And this is in line with World Breastfeeding Week that is happening this week. And so we're very happy to be doing this, and we're really delighted to have our series of presenters with us. So as I said, I will be filling in for Dele Abagunde to open up the webinar, but then I will pass it on to my colleagues at Breakthrough Action, Shitu Abdu Aguye, who is also the Deputy Chief of Party at Breakthrough Action. And he will be followed by Udo Chisholm Anaba, who's our research analyst at Breakthrough Research, to provide some of the results. So if we could just go to the next slide. So just to give a brief overview of this webinar, we'll first provide a brief overview of Breakthrough Research and our project. The webinar will then go into what is the Behavioral Sentinel Surveillance Survey, which is the basis for the results which we'll be presenting. And then we'll focus on breastfeeding practices, including the formative research that informed the survey that we conducted, the new ideational metrics that we developed for data collection within the survey, key findings related to breastfeeding, and then the implications of these findings for the Breakthrough Action program and social behavior change in northwestern Nigeria. And then I'll finish up with some of the future work and implications of these findings. Next slide. So Breakthrough Research is USAID's flagship project for social and behavior change, or SBC, research and evaluation. We are a 5-year project that began in August 2017 and ends in July 22. We work in multiple countries. The Breakthrough Research project in Nigeria in particular, that activity started in January of 2019, and our office only opened in September of 2019. That also coincided with fielding of the baseline survey. That's the basis for the results we're presenting here today. And of course, we work in very close collaboration with our sister project, Breakthrough Action, which is USAID's flagship project for social and behavior change programming. And we work with other IPs as well in Nigeria. Next slide. So now I'll turn it over to my colleague Shitu Abdu Aguye from Breakthrough Action, who will give you some background on their work and the social behavior change programming in northwestern Nigeria.
So thank you, Emily. Good morning and good afternoon, everyone. In the next few slides, I'll just tell you a little bit about Breakthrough Action. Breakthrough Action is USAID's flagship social behavior change program globally, with presence in over 28 countries or worldwide. In Nigeria, the goal of the Breakthrough Action Nigeria project is to increase the practice of 17 priority health behaviors in the area of maternal, newborn, and child health, nutrition, family planning, and malaria. Our intermediate results are around improving individual and social determinants of health and ideation around the priority behaviors, strengthening SBC coordination and collaboration among USG partners, key of which are Breakthrough Research, IHP Integrated Health Project, and the Global Health Supply Chain Project. Our third intermediate result is strengthening SBC capacity of national and subnational public sector entities, working closely with MDAs of governments, the Federal Ministry of Health, National Primary Care Development Agency, and their corollaries at the state level. Next slide. With 17 priority behaviors, we have to find a logical way to cluster them in a way that we can conduct SBC activities that are coordinated and make sense to the audience that we're trying to address. So we have here several milestones along which we've clustered the various behaviors that breakthrough action works on. The milestones range from behaviors that happen pre-pregnancy to behaviors that occur when the child is between 2 to 5 years old. And you'll see that these behaviors cut across maternal health, child health, nutrition, malaria, and other aspects of MNCH. Next slide. Breakthrough action uses a coordinated multi-channel approach for implementing our activities. There are 5 of those approaches. We have the community mobilization approach, under which we have community social behavioral change, community SBC, and community capacity and sustainability activities. Community SBC involves group dialogues with groups and individuals at community level to create demand for the services around the priority behaviors. Community capacity and sustainability is around strengthening the capacity of community structures to coordinate and plan interventions for their own health at community level. The mass media activities is where we have the popular Abishirunku radio drama series. Abishirunku is a daily 5-minute radio drama that explores the journey of a couple through pregnancy and childbirth, and looking at the perspectives of different players on the couple's lives, the couple themselves, the influencer, family influencer, religious leader, health provider, and all the 5 episodes, daily episodes, are clustered together as a 25-minute episode at the end of the week, and it's quite popular in Bauchi, Sokoto, and Kebbi, where we implement. The mobile digital approach is cross-cutting, supports every other intervention that we have, using SMS, IVR, and other tools to support activities in the other areas. We work with religious leaders on advocacy around social and gender norms. This is a key component of our approach, of our strategy, and it's being implemented in all the states where we work. Our provider behavior change activities look at providers' ability to implement guidelines around malaria prevention and treatment, and also respectful maternal care. Next slide. Breakthrough action works in 11 states and FCT. This is our current configuration, or something that will begin in October this year. The BSS study that Breakthrough Research has conducted is actually been has been conducted in Sokoto and Kebbi and Zamfara states. Sokoto and Kebbi being the intermediate states, and Zamfara state being the vertical malaria state, where the outcomes are being compared. Next slide. So I'll hand over back to Udo, I think. Thank you.
Thank you, Emily and Shitu. My name is Udo Anaba. I'm the research coordinator at Breakthrough Research Nigeria. So I'm going to talk about the Behavioral Sentinel Surveillance Survey, the BSS survey in general, and some of our specific research results related to breastfeeding. And we looked at 2 outcomes here. One was immediate breastfeeding within 1 hour after birth, and the second was exclusive breastfeeding for the first 6 months of life. So first of all, the main objective of the BSS was to assess the effectiveness of integrated versus malaria-only social behavior change SBC programming on malaria, family planning, and MNCH+N outcomes among pregnant women and women with a child under 2 years who live in Breakthrough Action Program areas. So the BSS measures priority behavioral outcomes across each of these health areas, and also psychosocial influences or ideations across cognitive, emotional, and social domains, all of which have been theorized as intermediate or indirect determinants of behavioral actions and decision making. So the psychosocial factors across each health area were developed based on the Kincaid theory of strategic communication and behavior change. And this model captures the complex psychological and social interaction pathways that leads to behavior change. So here, communication is considered as an outside factor affecting other variables in this model. So this theory shows a pathway from exposure to communication activities, which breakthrough action is already carrying out through their mass media, advocacy, and community activities through 3 ideational domains, which are the cognitive, emotional, and social domains, and 9 ideational subdomains, leading to changes in intentions and behaviors. So what's unique about this model? Let me draw your attention to the box in the middle titled ideation. So individually, these ideational factors have been recognized as key factors for influencing behavior. And so this model combines several behavior change models and theories in one. So we can view ideations acting as a sandwich between the recall of messages, that is from communication activities, and then changes in intentions and behavior. So our survey questions were intended to measure as many of these ideational domains as possible across all of the priority health behaviors. So if you recall, Shitu mentioned that we have 17 core behaviors based on by breakthrough action. And here we have 9 subdomains in this model, and that gave us a minimum of about 153 questions to get a comprehensive look at the drivers of all priority behaviors. And just to add, we had many more questions than that, probably over 300 additional questions. And even then, it wasn't as comprehensive as we would have wanted. But we had to strike a balance between being comprehensive and also risking respondent fatigue, which we feel may have jeopardized the overall quality of the study. So the main study populations for the BSS were currently pregnant women and also women with a child under the age of 2 years. And these populations correspond to the main life stages focused on by breakthrough action. Specifically, they focus on the priority 1,000-day window. And by 1,000, that means the period from pregnancy to when the child celebrates their 2nd birthday. We collected data in all 3 states, but these data are only representative of the breakthrough action program areas and not the entire states themselves. The study design involves both cross-sectional and cohort components. To provide estimates of prevalence of behaviors and ideations over time, we will use repeated cross-sections of women with a recent completed pregnancy at 3 points in time. We're also following a cohort of women who were pregnant at the time of the baseline survey so that we could document their 1,000-day window experience. So there is a quasi-experimental component in this study in the sense that we are comparing geographies with integrated programming, that is in Kebbi and Sokoto, with those with vertical programming in Zamfara. The sample sizes included just over 3,000 women who were pregnant at the time of the survey, and another 3,000 women with a recent pregnancy who were selected through random sampling. So in the presentation today, we present both bivariate and multivariate analysis. And for the multivariate analysis, we will present the predicted probabilities of an outcome occurring based on mixed effects logistic regression models adjusted for ideational and socio-demographic variables. So the final baseline technical report is now publicly available and it's on our website through this link listed below. And it includes a full description of the survey methods and complete descriptive results with over 500 indicators reported by states. And I encourage us to download the report to get a sense of the breadth and richness of the data collected. So how did formative research inform the BSS? Breakthrough Action, which is our sister project, had conducted wide-ranging formative work during its first year. And we drew upon this in developing the survey questionnaire. Some of their results from literature reviews and qualitative interviews digged deep around the reasons for not practicing exclusive breastfeeding, women's perceptions of early initiation of breastfeeding, and also their perceptions on exclusive breastfeeding. And all of this information helped us shape the questions we asked in our survey. So there are lots of ideational metrics in the literature related to knowledge, attitudes, and intentions for health areas such as family planning and malaria, but the literature is scarce for other health areas, including breastfeeding. And why is it important to have this kind of information? This is because in the theory of strategic communication and behavior change I had talked about earlier, ideational factors are so important and they form the basis for investment in breakthrough action, both here in Nigeria and globally. So it's important to see what the underlying relationships are between ideational factors and behaviors. The questionnaire was developed jointly with Breakthrough Action and also with input from other experts. We made attempts to use previous research wherever possible, but that was limited for many maternal newborn childhood nutrition areas, including breastfeeding. And again, as I mentioned earlier, we had to ask a limited set of ideational questions across each health area, or our questionnaire would have been very long. We also prioritize these questions based on their programmatic importance. So here are the ideational questions included for breastfeeding. For each health area, we try to have at least one question for each specific ideational domain. For example, for knowledge, we asked, in your opinion, what is the ideal age to begin introducing complementary food in addition to breast milk? And then we coded the data for analysis as those who provided correct answers versus those who did not. And for beliefs, we had questions such as, a mother's breast milk after birth is bad milk. And we coded questions to this question, we coded responses to this question as strongly agree, somewhat disagree, strongly disagree, or don't know. We also included questions related to emotional and social domains, including self-efficacy, Likert scale statements, and questions about social influences on decision-making. So I'll present the key findings for breastfeeding according to SBC program priorities. So number one, behavioral patterns. We asked, how frequently do respondents practice the promoted health behavior, and what are the key behavioral patterns? For knowledge and beliefs, are respondents aware of promoted health behaviors? Are certain beliefs held that could impede progress? For barriers, what are the common reasons for choosing not to do a promoted health behavior? For social influence and decision making, we asked who mainly influences your healthcare decision. And lastly, for ideational relationships, we wanted to understand what's the relationship of these various psychosocial influences on uptake of the promoted behavior. So in this slide, we can see that while a lot of the women ever breastfed their child, less than half initiated breastfeeding within 1 hour after birth, and even less practiced exclusive breastfeeding for the first 6 months of their infant's life. Giving non-breast milk liquids within the first 3 days of life is widely practiced among the women, and these may have contributed to these results. So in this slide and the next slide, you will see there is low practice of early initiation of breastfeeding within 1 hour, and also for exclusive breastfeeding within the first 6 months. So importantly, immediate breastfeeding and exclusive breastfeeding practices were low, especially in the integrated states, and also inequitable in this area. And this variability in exclusive breastfeeding rates is also seen in mapping rates at the local government area level within these states, with some extremely low levels found in the southern parts of Kebbi. So we found low knowledge of the benefits of breastfeeding. Nearly half of the women reported no benefits or didn't know any benefits, any breastfeeding benefits for the mother. However, we found higher knowledge of knowing any benefits of breastfeeding in malaria-only states, that's in Zamfara, compared to the integrated states in Kebbi and Sokoto. We can see from this slide that almost 2/3 of the women believe they should breastfeed for about 12 to 23 months. So while this looks promising, we also want these women to understand the benefits of not just breastfeeding, but taking advantage of the critical points to initiate breastfeeding early and continue to breastfeed without giving water or complementary foods for up to 6 months. So most women believe that breast milk contains essential nutrients for the first 6 months of life. And almost half of them, which is 2 out of 5 women, believe it is the norm for women to exclusively breastfeed for the first 6 months. However, the myth that breast milk after birth, that is colostrum, is bad milk, still persists. So we asked women who did not report exclusively breastfeeding about reasons for non-practice, and the most commonly cited reason was their personal refusal to eat and also spousal refusal. Another important reason was that some felt it was not necessary, and also that breast milk was considered inadequate milk for the child. But we did not ask further questions about the nature or reasons for these oppositions. So when we asked women who besides themselves may influence their decision to breastfeed, the majority of women reported their spouse or husband. But in our multivariate analysis, we found no significant association between spousal influence and early initiation or exclusive breastfeeding practices. So the next series of slides will show the significant associations we found between other psychosocial factors or ideations and early initiation and exclusive breastfeeding practices. So I mentioned earlier in the study design, we ran mixed effects logistic regression models, and we controlled for a number of things like age, education, wealth, occupation. And the advantage of regression analysis is that it allows us to tease out the independent effects of key ideational factors like knowledge, beliefs, self-efficacy, norms, etc., holding constant all other things that could affect those outcomes, such as differences in age, differences in educational status, income, etc. So from there, we can identify which ideational factors are likely to serve as the strongest levers in achieving behavior change. The first slide looks at practicing exclusive breastfeeding as a function of knowledge of the benefits of breastfeeding. So women who knew at least one breastfeeding benefit were 1.5 times more likely to exclusively breastfeed than those who did not. So secondly, women who knew that immediate breastfeeding protected a newborn after delivery were 1.54 times as likely to exclusive breastfeed compared to those who did not. And lastly, women who knew that 6 months was the ideal age to introduce complementary feeding in addition to breastfeeding were 1.5 times more likely to exclusively breastfeed than those who did not. Self-efficacy in being confident that a woman can exclusively breastfeed and beliefs around colostrum were also significantly related. Women who did not believe that breast milk after birth is bad were 1.5 times more likely to exclusively breastfeed. Secondly, women who believed that it was important to exclusively breastfeed were 1.4 times to practice this And lastly, for self-efficacy, women who had confidence to exclusively breastfeed were 1.6 times more likely to do so than those who were uncertain. So we did the same thing for early breastfeeding. Here we see that ANC attendance, knowledge, and beliefs about breastfeeding were significantly associated with early initiation of breastfeeding. For knowledge, women who knew that breastfeeding was a way to protect their newborns after delivery were 1.2 times more likely to start breastfeeding within 1 hour after birth. For beliefs, women who did not believe that breast milk after birth is bad milk were 1.2 times more likely to start breastfeeding within 1 hour of birth. And lastly, antenatal care attendance of 4 or more times was associated with initiating breastfeeding within 1 hour of birth. So what are other determinants of breastfeeding practices? Attending ANC 4 or more times had a significant effect on early initiation of breastfeeding, but not for exclusive breastfeeding. Health providers had a significant influence on the women's decision to breastfeed, but spousal influence was not statistically significant. We found no significant socio-demographic influence on exclusive breastfeeding after our multivariate analysis. So only ideations of knowledge, beliefs, and self-efficacy were significant for exclusive breastfeeding. And lastly, household wealth and maternal employment were associated with early initiation of breastfeeding. And this, in addition to the ideations of knowledge about the benefits of immediate breastfeeding and beliefs around colostrum. So what do all these analyses tell us? It tells us which levers the social behavior change program carried out by Breakthrough Action can pull to have the largest effect. You can see knowledge, beliefs, and self-efficacy are clearly going to have important effects. And if the SBC program can improve these indicators, then they can improve immediate breastfeeding and exclusive breastfeeding rates by many multiples. I will now turn the presentation back to Shitu, who will discuss the program implications of these findings and how Breakthrough Action will use these results for program learning and adaptation. Thank you.
Thank you, Udo. Next slide, please. So the first broad area there is the focusing SBC programming on early breastfeeding practices. Now, dispelling common misperceptions that colostrum is bad milk is something that Breakthrough Action is currently actively working on with our community mobilization approach, mass media, and advocacy with religious leaders. We've crafted messages around this and which have been implemented and rolled out in the various activities at community level. Addressing widespread practice of giving breast milk liquids in the first 3 days is also something that we're actively already working on with various community level approaches. There are many liquids that are given. In the work that we did earlier that Udo mentioned, we had things around local concoctions and herbs. We had things around orange juice. We had things around water, all different things. And I think there's still a lot of things we've not yet learned about. And we'll definitely be exploring to learn more about what kind of foods are given in the first few days of life. Improving ANC quality and reach as a potential gateway moment is critical. And ANC is also one of the behaviors that we're working to shift the needle on in the communities where we work. Breastfeeding counseling should actually start from ANC, and there should be 6 sessions, some that happen while the woman is still pregnant and others that happen during delivery and after delivery. And the mindset, the decision to breastfeed really starts when the woman is pregnant, and that's counseling needs to happen from the antenatal period. The cluster of poor exclusive breastfeeding that was observed in Kebbi, Southwest Kebbi, was an interesting finding from this study, which we're going to be investigating. COVID-19 has not allowed us to visit those areas yet, but definitely we'll go there to find out what's maybe the cause of this cluster of poor practices in that part of the state. It may be due to cultural norms or social norms. We will definitely be finding out what's going on with these in the next couple of weeks and months. Next slide. So tailoring SBC messaging to address knowledge, beliefs, and self-efficacy. Emphasizing breastfeeding benefits for mothers and newborns. That's something we're already implementing on Breakthrough Action. Ensuring women know how long to breastfeed and when to introduce complementary foods. These are things that we're already also implementing, but also there's a service delivery aspect of this counseling that should happen at the health facilities when women go for ANC. Dispelling misperceptions that breast milk after birth is bad milk to improve early and exclusive breastfeeding practices. I've mentioned this, we're already working on this. Support women's confidence to exclusively breastfeed for the first 6 months of life. Yes, this is, again, you have to build the woman's confidence to do this starting from ANC. And we're addressing this also as part of our SBC activities at community level. Religious leaders and community leaders are also advocates that we're engaging to ensure that we shift norms around breastfeeding. And there needs research to further explore women's own opposition to exclusive breastfeeding, and the role of spousal opposition is something that I'm sure Breakthrough Research will conduct or look into during the midline BSS and probably the end line as well. Next slide. Okay, back to Emily. Thank you.
Okay, thanks Shitu and thanks Udo, both of you, for a really great presentation on the on breastfeeding results and also their implications for SBC programs going forward. I will finish out this webinar by talking about what's next now. So you can go to the next slide. So in terms of our immediate next steps, we're going to continue conducting analysis of this BSS baseline data set to further inform Breakthrough Action program adaption and scale up. We're going to convert these webinars and the research briefs that go along with the webinars that's available on our website into research manuscripts and briefs to disseminate results to global and national audiences. And we're now starting to prepare for the midline survey, which was originally supposed to take place in September of this year, but of course it's being delayed due to COVID and also due to the fact that Breakthrough Action programming has paused for a while, and so we'll need for Breakthrough Action to get up and running for at least a few months before we can implement a midline. So it looks like the midline survey will occur maybe at the end of this year, early next year, but we're still looking into this. This is still to be discussed. And then of course we'll have an end line at the end of the project in late 2021. And finally, we are continuing with our webinar series to present these BSS results by each specific health area. And if you can go to the next slide, that will show the webinar topics and the webinar schedule. So we've done our first, I guess, 4 global and national webinars, as well as one for pregnancy and childbirth and one on breastfeeding. And the next one will be on August 20th that will focus on vaccination results from this baseline data set. So please, we hope that you'll join us and let your colleagues know to also join us for that next webinar. Next slide. And in terms of just future work and significance of all of this, just to take a step back and look at the big picture. So we've presented to you the baseline results from the BSS evaluation. And this is really a first step for assessing the overall effectiveness and cost benefit of integrated versus malaria-only SBC programming in Nigeria, right? So we've done a baseline, and then the effectiveness study will use the midline and endline results to get at that. We're going to further highlight ideations and behaviors during this baseline period to continue to inform SBC program scale up and adaption. This is a big data set with a lot of rich data that we can still further mine and explore to inform programs as needed. We've again described some of the new metrics or psychosocial metrics that we developed for the BSS, and we want to present these new ideational metrics in different forums for MNCH areas, and we'll also continue to quantify their relationship with behavioral actions to test this Kincaid's behavioral change theory. And finally, additional work would include linking these survey results with other routine program data or even health facility records or health facility assessments to examine both the supply and demand side factors on service delivery and uptake across these different health areas. So that's some of the big picture work we hope to do over the life of the Breakthrough Research Project. Next slide. And finally, just to really acknowledge the large project team that we're working with, the PIs on this study are Paul Hutchinson from Tulane University. He's also on vacation this week, and Paul Hewitt, who's a co-PI from the Population Council, who's a panelist with us. But of course, a large survey team, including our colleagues from CRARED, who we've worked with, our colleagues from Breakthrough Action, including Shitu, Ian Tweedy, the chief of party there, Stella Babalola, who gave a lot of input into the BSS questionnaire and design, as well as Matthew Oko and other colleagues. So just also to acknowledge and recognize the project team that made this possible. Next slide. And again, thank you to all of you for coming to this webinar, for participating in it. We have about 15 minutes left, where we usually have a question and answer period at the end of the presentations. So I can actually moderate that too a bit. I was going to do that while Dolly presented, but I will do that now. So I know earlier on there was interesting discussions in the chat box about the colostrum as bad milk finding from the BSS survey. And I know Shitu talked a little bit about that during his presentation. I'm wondering if Immaculata, who raised this point in the chat box, wants to ask a specific question, or if Shitu wants to respond to some of what was written about the linkages with colostrum as bad milk. What they're doing for it, and if they're linking with other programs such as family planning or diarrhea that would also be affected by this misperception of breast milk after birth.
Right, so I think Immaculata is talking about, again, it's more around the benefits of breastfeeding and sort of linking them with other outcomes that the mother and child can experience when the child has early and exclusive breastfeeding. She talks about colostrum being the first immunization for the child, which is true. Exclusive breastfeeding preventing childhood killer diseases like diarrhea, and also exclusive breastfeeding being a birth control method, childbirth spacing method as we call it, if done appropriately with all the criteria met. So I think she's trying to establish linkages between breastfeeding and other outcomes that the woman and child experience. I don't know if she has a specific question she wants to ask, but these are also linkages we've also made in the messages we pass at community level around breastfeeding and how we address the various audiences around the topic.
Thanks, Shitu. No, I think that's a really helpful response. I see another question in the chat box regarding, and it's Teza Lightborn who's asked if we could please explain the difference between personal advocacy and self-efficacy. Does personal advocacy mean the mother's ability to advocate for themselves? And if so, how is this different from confidence to take the behavior of interest? And I will just say that the questions that were asked in our questionnaire for self-efficacy, or that domain, really refer to confidence to doing the promoted behavior. So the woman is asked, how confident do you feel in exclusive completely breastfeeding your child for the first 6 months of life. So it's really about confidence in this respect. There's other questions sometimes about the woman's confidence in starting conversations with their husband, about doing the promoted behavior too. So I hope that that also answers that question from Teza Lightborn.
If I may add
There's
to that.
Sure, yes, please.
Personal advocacy coupling is about the mother's ability to advocate for the behavior among her peers or anybody else around her. Not necessarily for herself.
Yes, and that's in your SBC messaging and SBC programming too with Breakthrough Action. Is that correct?
Yes.
No. But in the questionnaire, we're only asking about confidence, but that is absolutely another part of the self-efficacy and personal efficacy component in social behavior change messaging. Another question from Teza Lightburn in the chat box is regarding COVID-19, where mothers encourage that colostrum is beneficial for strengthening the baby's immune system. I guess immune system with respect to having reduced the disease severity from COVID. Do you know of any SBC messaging surrounding breastfeeding and COVID, Shitu?
Yes.
And just to say that our survey was done before the COVID pandemic, so there were no questions related to this in our survey. But Shitu, go on, please.
Yeah, the mothers were encouraged. We did adapt messages for the COVID-19 pandemic, and mothers were encouraged to continue breastfeeding because of the beneficial effects of the breast milk in preventing diarrheal diseases, pneumonia, and other things because of the antibodies in the breast milk. It doesn't actually specifically strengthen the child's immunity, but the antibodies contained in the breast milk help to prevent those common childhood diseases. So yes, we did adjust our messaging to emphasize that during COVID-19 outbreak.
Thanks a lot, Shitu, for responding to that question too. I know that Breakthrough Action has been heavily involved in a lot of the COVID-19 social and behavior change messaging related to COVID-19 in Nigeria. So they are also well placed to talk across many issues related to COVID-19. Another question from Nigel James is, how does staff shortages in clinics impact your intervention in MNCH areas that you are working? And by staff, meaning health workers. So I guess how staff shortages impact social behavior change messaging or other interventions in maternal newborn child health. Shitu, do you want to speak to that? Then I can just quickly say before Shitu jumps in that you know, the BSS survey is at the population level, so we're interviewing women in the community. So we don't know necessarily about staff shortages from these results, but we do know women's perceptions of health services from a number of questions in terms of their perceptions of quality, etc. So we can talk a little bit about that, but we can't speak to this question specifically. But Shitu, do you want to talk a little bit about how BA works with health services delivery and staff shortages in clinics impacting interventions and social behavior change messaging?
Okay, thank you. Staff shortages are more or less a pervasive problem really everywhere, that's in most developing countries. And I did mention that we're working with our USAID partners at the beginning. IHP, the Integrated Health Projects, have the service delivery partner that we work very closely with. They work on health system strengthening and quality issues at the health facilities. So they're actually working to ensure that the system is able to provide the staff required to absorb the demand created from community level to ensure that clients get the services they need. So we do the referrals at community level, and then the challenge clients may face is getting to the facility and not getting the required care they need if the staff is not available. But this is something that IHP is closely working to address, and increasingly we're seeing getting feedback about clients getting the kind of services they require and the quality of services improving as the projects progress.
Thanks, Shitu. That's really helpful. And just to remind other participants, if you do have questions, please put them in the chat box, and then we'll take them up now. We have another 5 or 10 minutes. There is one more question now from Muktar Gaya from Breakthrough Action, saying that from the presentation so far, Zamfara, the control state, seems to have better indices than the integrated states. Was any effort made to find out whether IPs implemented or currently implemented maternal newborn child health interventions in the state in the recent past? And just in terms of the BSS results, yes, we do see overall across many different health areas better results in Zamfara than in Kebbi and Sokoto. And we are now and will continue to look at what's being done in Zamfara in terms of IP programming across these different health areas in order to further inform our results from these areas, particularly as we go forward from midline and endline. So we'll work closely with the VA team at the state levels and their state coordinators to understand exactly what programming is also going on in there to explain these results. It could, of course, also not be a result of programming per se, but also other factors as well, just socioeconomic or demographic too. So we are going to look into that to further explain the reason for the better results in Zamfara than in the integrated states. Shitu, do you want to add to that? Or should we move on to the next question?
You can move on, I think that's fine.
Okay, there aren't any more questions in the chat box except one from Kara Shefef, who just said that she thinks this research is really incredible and helpful and wants to thank us. And so we are all, just to say thank you for that comment. We're really appreciative of it. And we're really happy and excited to share this work with all of you. We agree, we think this data set is really rich. It provides a wealth of information, not just on the behavioral outcomes that you see in general DHS, but also these ideational factors that really, in some ways, help to explain what's going on and some reasons for the outcomes that we're seeing that can inform social behavior change programs, but really other programs too to help improve these rates going forward. So just to say that we thank you for that comment, and we're also very excited about the richness of this data. So I think with that, since there's no more comments, I guess we can close out this webinar session. And just to say that I hope everyone will join us for our next webinar in 2 weeks on vaccination, and to give a very hearty thanks to USAID, who funds both Breakthrough Action and Breakthrough Research, for supporting our work. And again, to say thank you to the presenters who are really great today. Shitu Aguye, who's the Deputy Chief of Party at Breakthrough Action and a real partner in this work, and Udo Chisholm Anaba, who's a stellar research analyst with Breakthrough Research in Nigeria and really led the analysis for the breastfeeding and nutrition. So we hope to see you in 2 weeks' time and in our future webinars on other health area specific topics. Thank you again for joining us today.